relates to deformity surgery and how degenerative surgeons are essentially deformity surgeons as well. And I'll let some of the senior guys start to argue about which way is best. These are my disclosures. This is what I do for a living, and this is what I see here in Florida. So there's not that many surgeries that cannot be considered deformity surgeries, especially if you're trying to do a minimally invasive like this. And this is another one of my patients that was fused multiple times around the Florida area, and finally came to me, and we were able to realign him with the appropriate surgery that he needed, but he had to get 7 surgeries before that, unfortunately. So, as an overview, degenerative spine pathology makes up a predominant majority of what we treat, right? Understanding that segmental alignment in the lumbar spine is much more important, as Dr. Tresser alluded to earlier. And adjacent segment disease is something that I think we can prevent. It's not something that we cannot control. I think there's uncontrollable factors, but we have to understand the principles that we're trying to treat to achieve success in deformity in degenerative surgery. We're seeing an extreme increase in elective lumbar fusions over the last few decades, which has been up 62% from 2004 to 2015 alone. These trends, as you see, as we follow the trends out for 15 years, there hasn't been much change in trauma, tumor, infection, and deformity, but if you watch the trends for the increase in degenerative pathology, it's been skyrocketing. And this has been shown to be worldwide due to the incidence of degenerative spine disease. There's approximately 3.6% of patients worldwide, which equates to 266 million individuals that are diagnosed with this yearly. So how should we evaluate these patients in our clinic, right? We can't all do standing films and full-length cassettes, but we need to be aware of these pelvic parameters in all the patients that we're treating. And there's an alphabet soup of things that we can look at, but which ones are important, and how can we look at them? And do we need full-length standing films to accurately evaluate all these patients? The right looks more like my clinic, unfortunately. I'm not able to get these full-length standing films unless I specifically ask for them, send the patient back, and those are my scoliosis patients. But if you look at the radiology literature, it actually supports us being able to accurately measure spinal pelvic parameters as long as we're able to include the entire lumbar spine and the femoral head. So there's no reason why in anyone's clinic that we can't look at these pelvic parameters. And what should we be looking at, right? Schwab's classification really did a great job of allowing us to kind of explain what the deformity looks like from a coronal and sagittal with their modifiers, and to look at these parameters and help with treatment. But not everyone needs a Schwab classification. And then obviously there's new modalities such as the GAP score, right? So the Global Alignment and Proportion score. And this has been put out by the ESSG to help us look at limiting complications. And this is actually a pelvic incidence-based parameter where they took essentially they looked at the overall tilt as well as the slope and the lordosis and came up with this parameter and included age to help you predict failure rates and complications with your patients. Again, something that we need to be mindful of, and something that the GAP score included was the look at segmental lordosis as well, and separating out L4 to S1 lordosis over global lordosis. And then Rusoli looked at these parameters from different pelvic subtypes, right? So he looked at 4 different parameters: low pelvic incidence, types 1 and type 2, and higher pelvic incidence, type 3 and type 4. And this becomes really important when you think about how to treat your patients, right? Not everyone needs a hyperlordotic A-lift, but a type 4 may need that to accurately restore their alignment at L5-S1. And Rusoli further looked at this and how does the Rusoli subtypes relate to degenerative pathology. And they actually found reasonable associations with these higher pelvic incidence types 3 and type 4 with diseases such as degenerative spondylolisthesis or lytic spondylolisthesis, that they had a significantly higher pelvic incidence compared to the type 1 and type 2, which had a higher proportion incidence of just degenerative disc disease, disc herniations. And these are the patients that may do well with less sagittal correction. Right, and then the mean study actually was a really interesting study that looked at 468 volunteers that were asymptomatic And does age matter is something that they wanted to look at. And interestingly enough, when they followed their lordosis out over the spectrum, they did, in the absence of deformity or degenerative pathology, they didn't find any increase in the actual lumbar lordosis. What they did find was an appreciable increase in thoracic kyphosis, which is something we see as we age. But maybe there isn't as much to age adjusted as we think. And I think this is unfortunately something that's still to be determined. They also looked at the segmental alignment of these patients, and they found that the incidence of increase in lumbar lordosis, and that increased as your pelvic incidence increased, but it increased in the L1 to L4 region because we've already maxed out our lordosis from the L4 to S1 region. And that being said, can we start to predict failure of these patients? And there's argument to say that we can. So this paper, excuse me, out of the European Journal of Spine looked at two types of alignment post-operatively, where you aligned your post-operative patients with a PILO mismatch of less than 15 degrees or a PILO mismatch of greater than 15 degrees post-operatively. And the findings showed that the incidence of needing a revision surgery or risk of revision surgery was threefold in those patients that you didn't restore the adequate pelvic PILO mismatch. Again, and this kind of shows why that is. If you look at the way the shear forces go through these sub-adjacent level disc segments, when you don't accurately restore their alignment in that segmental standard. And again, this is another paper that looked at patients that were left with a high PILO mismatch, which they defined as greater than 11 degrees. And again, they had a positive predictive value of a 75% increased risk of symptomatic adjacent level disease. Another paper out of Japan looking at patients with just a single level degenerative L4-5 for a spondylolisthesis with 5-year follow-up, and that incidence was found to be significantly higher in patients that did not have a segmental lordotic change. And they found that those patients actually had a higher level of risk if we left these patients kyphotic. And so let's talk a little bit about segmental lordosis and what it means. And so the restoration of lordosis is significantly important, not just from a global standpoint, but from a segmental standpoint. We're going to see reciprocal changes in our global lordosis in most of our patients. In a one-level degenerative spondylolisthesis, we may not see a global realignment. And this was a great illustration out of Brown with some of the ISSG guys and Alan Daniels, and it shows you that there's the main driver in most of these patients, and there's the compensation. And we want to evaluate whether that they have cephalad or caudal compensation, or they have just global malalignment, and that helps us treat these patients more appropriately. They looked at this recently out of the ISSG, and they looked at defining surgical targets for our lumbar lordosis. And we started 10 years ago with, let's get as much lordosis as possible, and that went to our PILO mismatch needs to be less than 10 degrees. And now we're looking at actual calculated segmental correction. And we know that the distribution of the lordosis should be higher from the L4 to S1 level, but this is going to vary by our pelvic incidence. So the higher the pelvic incidence, the more lordosis we can apply to the L1 to L4 level. So that apex of lordosis migrates. And Alan came up with a chart here to kind of utilize how high your pelvic incidence is and what your target range should be for that specific level when doing segmental correction. Again, this is another paper just showing the incidence of adjacent level disease and how important it is to correct here they measured the L4 to S1 ratio over your global lordosis. And those patients that had a correction of their L4 to S1 had a significantly reduced reduction of adjacent segment disease. Another great paper out of Japan showing improvement of lumbar lordosis. And this was Kepler's paper looking at degenerative spondylolisthesis and how restoration of anatomic segmental lordosis actually realigns our global lordosis. You may actually see a reduction in overall global lordosis because of that compensation that we saw in Alan Daniels' paper. So it actually is going to decrease the PILO mismatch, but it's going to improve your overall global alignment. This was a recent paper looking at a kind of a retrospective review, which was interesting. They looked at approximately from 2006 to 2012. So they had, I think, a 6-year follow-up looking at preoperative and postoperative pelvic parameters. And their endpoint was looking at revision for adjacent level disease. And again, they saw there was just this incremental increase in their revision surgeries and their positive predictive value for patients that were left with a PIL mismatch. And these were degenerative patients, right? This was, again, another review paper out of Brown with Alan Daniels. They just put out, and they looked at 885 studies recently. They had 43 met the inclusion criteria, looking at techniques to help correct segmental alignment. Again, this is an area where we're still learning a lot, unfortunately. This is a patient of mine that was unfortunately fused focally kyphotic after a TLIF with unilateral fixation. You see they had 5 degrees of lordosis from L4 to L5, and restoring that alignment is really important in figuring out how to prevent this from happening in the future. So how do we create lordosis, right? We want to reduce the slip angle. We're going to fuse these patients, right? Are we going to fuse them circumferentially with an ALIF, with a lateral, or a TLIF? Do we need to do an osteotomy, 3-column or a posterior-based osteotomy? And what is best? And I've got some great speakers here to argue about that later, so I'll just throw out some data and we'll go from there. And do we need to present, or do we need to treat everyone the same? This was actually a really interesting article that the French came out with, and they looked at the segmental correction that was needed, and they classified these patients with degenerative spondylolisthesis and whether or not they had a segmental alignment preserved or a decrease in their segmental lordosis, and whether they had preservation of their global lordosis. And we can look at treating these patients differently. Not everyone needs, like I said, a hyperlordotic ALIF to restore their alignment. And this was a paper looking at ALIF versus TLIF, and ALIF was found to be superior to TLIF in increased foraminal height as well as restoration of segmental lordosis, where incremental correction was about 6 degrees in ALIF and only 2 degrees in TLIF. This was another paper, this was the same paper. They looked at ALIF, TLIF, and PLIF, and again, they had the highest segmental correction with ALIF, only 4 degrees, but significantly higher than TLIF. Now, this was another one looking at ALIF versus TLIF for an isthmic spondylolisthesis. This was Andrew Simpson's paper that came out a few years ago looking at this, and they found to be a preferred technique utilizing ALIF in their hands with a significantly increased L4 to S1 lordosis, 11 degrees versus 1 degrees. Again, this was another paper, though, that showed that ALIF provided superior correction, but there was no clinical improvement in the HRQLs and health-related outcomes. So obviously a topic we still don't completely understand. And this was a paper looking at segmental correction, ALIF versus TLIF, for actual deformity out of the ISSG, and they found to have a significant increase in segmental lordotic correction as well as improvement in PIL mismatch in patients with ALIF or lateral versus TLIF. So, there's a lot of ways to treat these patients, and I think they're all appropriately in the right setting. We've got some great talks coming up that'll kind of elaborate on why theirs is the best. But in conclusions, to wrap it up, I think understanding the normal alignment of the spine and how to measure these parameters and what we're looking for are important in every patient. And then recognizing that segmental correction is something that we've kind of overlooked and now is very in vogue and thankfully so. And I think it's really going to help prevent some of these problems from happening in the future. And there are specific techniques that may help us, but we have options and we have a toolbox for that. So with that, I'm going to invite the next speaker up, and thanks for having me.